next talk is on living donor liver transplantation during the COVID-19 pandemic, a serendipitous silver lining. May I invite the speaker, Dr. Mohammad Rela. I also invite the chairpersons for this session, Dr. A.S. Soin, Dr. A.K. Balla, and Dr. Abhideep Chaudhary. Over to the chairpersons.
Good privilege to invite Dr. Mohammad Rela, who is a very senior pioneer in the field of liver transplantation, and he has his own institute at Chennai and one of the largest center in India, and he is known internationally as the liver transplant surgeon pioneer in India. And in fact, he was trained at London King George Hospital, and almost since last 11-12 years he is working, and he has already performed many hundreds of transplants in India. And he is one person who is interested in spreading the message of liver transplant. I request Dr. Mohammad Rela to start give his talk on liver transplant in the COVID era.
Good morning. My name is Dr. Mohammad Rela from Chennai. I'd like to thank the organizers, especially Dr. Vivek Kutte, for asking me to give this talk. He gave me the title of LDLT during COVID-19 pandemic, serendipitous silver lining. I'm sure that he did this because of this publication we had in transplantation, where we were looking at the outcome of transplantation and found that the patients were actually doing even better during the COVID era. And I'll just explain that. I think India suffered quite a lot with the COVID, with the second wave, which was much, much worse than the first wave with higher mortality. But when you look at, even though it's second on the league table, the mortality compared to the rest of the world, and also in terms of incidence per million population, India has done much better than most countries. Now, in the beginning, when during the early stages, this is a publication from Lancet Gastroenterology Hepatology in March 2020. At that time, the suggestion was that the COVID did not affect liver much, but they felt that clinicians cannot be complacent about the risk of COVID because these patients have very poor immune function. But that proved to be right, that liver was significantly affected due to COVID, and we wrote, we had a few patients admitted with decompensated liver disease and developed COVID and very rapidly died in ICU after admission. And we reported the first two cases very earlier on, and then wrote a review in Journal of Hepatology that COVID does affect the liver. And subsequent publications 3 months later, a multi-center Italian study clearly showed that patients with cirrhosis, if they contracted COVID, almost had a 30% mortality. So this is something that we need to understand, that we were worried about what happens to patients when they have a transplant, but even more importantly, if somebody is sitting in your hospital or at home with decompensated liver disease, if they develop COVID, there is a risk of almost a third of them will die of the COVID. Very similar results were seen in the rest of the world as well. This is an APASL multi-center study which also showed the same. Now, if chronic liver disease patients were dying while waiting for a transplant due to COVID, what happens? How can we offer transplantation for these patients was the question. Now, everybody stopped in the end of March, I think, or in the beginning of March, when COVID started. And one of the scary things at that time was this publication published in Lancet, which was an international study, which suggested that any operation, if patients having any operation contracted COVID, their mortality was high. So in this study, 24% had preoperative diagnosis and 76% had postoperative diagnosis of COVID-19. And you almost had a 24% mortality. And this was for any surgery, abdominal surgery, cholecystectomy, appendicectomy. And the at risk were male with a cancer diagnosis, major surgery, emergency surgery. So If one was to expect a 24% mortality with any surgery, then transplantation became out of question. Now, this was a very early study before the understanding of COVID-19, before the usage of steroids for COVID patients, and therefore this was a little bit redundant really subsequently, but following such publications, the number of transplantation or number of elective surgery dropped dramatically throughout the world, and it was almost, the suggestion was that elective operations should be cancelled and really only emergencies should be performed during the COVID period. Then we did a study of North American centers, UK centers that we knew, and also Indian centers, and found that in India during that time, in the month of March and April, almost there was a 100% drop in the activity. I think this is for a 2-week or 3-week period, compared to a drop in activity of about 80% and 60% in the United States and United Kingdom. So there was a significant drop in the activity. Around that time, really, most of the societies, ASLD, ILTS, everybody came up with guidelines for transplantation, but most had a view that transplantation is a tier 3B service, and therefore you should not stop the transplantation during COVID period. And they were even doing cadaver liver transplantation in the United States during that time. The Indian Liver Transplant Society also came up with recommendations, but these recommendations were a little bit more stringent than the Western recommendations, and it allowed only transplantation of patients with malignancy or patients with acute liver failure. And when it was cadaver liver transplantation, it could only be done with organs within the city, with no transporting or no sharing of organs across cities, and definitely not across the states. Now, the problem here for us was that if we stopped transplanting them, these patients had a very high waiting list mortality, because invariably, if they are sitting in hospital and if they contracted COVID, they were going to die. And initially, we only transplanted. So this was our activity. And the end of February itself, the activity started reducing. This is a weekly number. This is not a monthly number. We were doing about 4 to 5 transplants each week. And around the 15th of March, we stopped abruptly transplanting because of restrictions at that time, both with the government, with the travel, with people coming to hospital. Everything came to a standstill, so we stopped at that time. And then actually a month later, we wanted to restart the transplant because we had a 7-year-old with a decompensated Wilson's disease, and we wanted to transplant. This was like an acute on chronic. And we worked up the mother for transplant, and during the workup, we found that she turned positive, and therefore the transplant was cancelled for this child. I think we subsequently lost the child without transplantation. And then what happened, subsequently, 2 more patients with ACLF who was admitted in hospital and being worked up for transplant also contracted COVID and subsequently died. So this really put a fear in us as to how we can restart a transplant program. And at that time, the government was also very strict. And when we reported 3 cases with COVID in the early stages within the hospital, the corporation's view was that we were infecting these patients while they were admitted to hospital. And there was a huge, a massive contract tracing for these 3 patients who were admitted in hospital. Unfortunately, at that time, none of the clinical workers who were actually in contact with these patients were positive. So it was very clear that it was a community-acquired infection, and they came into the hospital with the COVID. Anyway, that was the beginning, and subsequently, as the rules were relaxed, we restarted the program with very stringent precautions. Patients had 2 COVID tests, one before their admission, and they were admitted to hospital with one relative, and both of them had to be tested. And then 5 days later, a day before the operation, they had a second test. So because they were isolated for 5 days and the second test is negative, both donor and recipient underwent an operation. Post-operatively, they were actually kept in ICU with no contact with relatives. The relatives were able to speak to the patients only on a Zoom call or on a video call or on a telephone call. The doctors did not meet. The outpatient appointments were cancelled, and they were all done as online consultation. So really, these patients were somewhat isolated and managed with full PPE by the ICU staff throughout. And in fact, most of them were discharged from the ICU, or because it was easy to care for them in ICU, because if we sent them to the ward, then it required a relative to come and stay with them. And we did not like the relatives to come and stay with them. So this is how we start, but slowly it was relaxed, and really in May we restarted. In between, we started in April, and it was shut down because some of the patients, the donors pre-operatively were infected, and in May we restarted the program, and from then on, really, we moved on. Now, coming to this title of the paper, Living Donor Liver Transplantation During COVID Pandemic, a Serendipitous Silver Lining, it comes from the fact that at the end of August, between April to August, when we looked at the outcome of these patients to see if any of them were infected post-operatively, we found that there was no COVID infection in any of the donor or recipient until they are discharged, and even in the immediate post-operative period, none of them developed COVID. Some developed much later, 3 months later, 4 months later, but had no mortality due to it. But perioperatively, for the first 3 months, there was no infection in either the donor or the recipient. And most surprisingly was the survival was 100% in these patients, partly due to very few post-operative infections, because there were very few visitors for these patients. They were managed with PPE by the staff, full PPE by the staff, and they were not exposed to the outside. Even the hospital did not have much footfall at that time, and we were quietly doing these operations in an isolated setting. And these patients, in fact, were discharged much earlier. So the post-operative, any infection complication, if you look at generally, maybe around 20 to 25%, and we had much less infective complication, which was statistically significant. And the hospital stay was also much less compared to a similar time previously. So we suggested whether we can actually continue with these in the post-COVID, at least some of these really, N95 masks to be worn by the surgeons during the operation and post-operatively by the nurses, restricting visitors for patients in ICU and make them speak to them by a Zoom call or a phone call, which is what we are continuing to follow. And the infection prevention precautions generally that was followed. Whatever can be applied in the post-COVID period, we applied, and that was a conclusion that we felt that LDLT could be performed safely during the COVID-19 pandemic, provided you take very special infection prevention precautions, and the outcome can be similar or even better during this period. And we felt that some of these infection precaution techniques can be carried over to the post-COVID period also to improve outcome of these patients. So this is what we have done from the time of April 2020 to September 2021. Last month, we have regained back our original numbers of over 20 transplants. It was 24 transplants. The first pandemic is what hit us quite hard, even though we were doing 4, 5, 6 transplants a month, which were mainly tumors and acute liver failure. But gradually, travel was also a problem for most of the patients who were coming from outside Chennai, and therefore the number of patients coming for transplant workup was also diminished. but the numbers increased up in March. During the second wave again, the numbers dropped, but now the numbers are going up once again. And out of 252 living donor liver transplants done during these months, about 16 months, we have had 5 deaths with a 98% survival in the perioperative period. In terms of COVID infection for these patients, there was only one donor who had COVID, who turned COVID positive in the immediate postoperative period, did not have severe illness, required admission though, and recovered without any complication. And there was no recipient who developed COVID in the immediate post-transplant period. So it's not been too bad an experience to perform living donor liver transplantation from COVID during the COVID period. And if we actually take suitable precautions, this can be done very safely with excellent outcome. Thank you very much.
Dr. Abhijit, Dr. Chaudhary.
Yeah, good morning, everyone. Professor Rela, it's always like the great talk, and it's always from coming from you, it's always the guidelines kind of a thing. So a couple of things, we also had the similar kind of experience. We published our 41 cases post-transplant COVID infections, and we didn't lose anyone. So you're absolutely right in saying that liver transplant is actually not causing any major problem when it comes to outcome of the recipients that develop COVID. The worry is always the donors, and luckily most of us have not had any bad experience till now, but the worry remains. And you said you are continuing to have some of your protocols which you changed during the COVID time. So are you implementing vaccine as one of the important change before you do the transplant?
I think the recommendation by really the consortium on surgery during COVID era, I mean, we were part of it. They say that vaccination saves lives because they are unlikely to get infections. I mean, if you look at the Western experience, unfortunately, the Italian, the UK, they all had very high mortality the first wave earlier on because we did not understand the disease. They did not have full treatment options that are available now. And that statistic still remains and becomes a comparative for current better outcome. I have a problem in enforcing vaccination before transplant. I don't know. We see more and more. Maybe the Americans and the Western world have got better vaccines. The RNA vaccines, the complication rates is not so high. But maybe as a specialist unit, you must do as well. We have seen quite a number of cholestatic presentations post-COVID vaccination. We even published in autoimmunity 2 cases of very severe cholestasis and 1 with liver failure. We've actually transplanted another, not a donor, another patient who had vaccination and had liver failure. It's hard to think it's coincidental. Now we treat them with the anticoagulation, and the cholestasis seems to improve with clopidogrel and aspirin. So we don't stop them from getting vaccinated. The general advice is that everybody should be vaccinated. But if they're not fully vaccinated or have had only 1 dose of vaccine prior to donation, I do not insist on a second dose, because the last thing I want is post donation that they become cholestatic or after the second week or third week, and we don't know what is causing the cholestasis. It'll always be attributed to the surgery and not to the COVID vaccination. So there are some centers in the West who have put vaccination mandatory before transplantation, and also vaccination mandatory for elective surgery too. But there is an issue here which is not completely resolved or understood. If you go to the companies and say that there are complications that we see post-COVID vaccination, that will be seen as a very negative thing and will put off people from getting vaccinated. It is true that vaccination saves lives, but to push people to get vaccinated prior to surgery is still a little controversial to me.
I completely agree with you, and this is kind of a similar experience we had. Actually, one of a family friend's wife, and she was supposed to be the donor. And after the second vaccination, she got pain abdomen, and when we did the ultrasound, she had portal vein thrombus. And then we worked up she had a rare kind of like thing, or not rare, I mean protein C deficient, and but incidentally picked up. So yeah, our worry is actually the same. What happens and how these people are going to respond. So I totally agree with you. But yeah, we have seen people who were vaccinated had comparatively milder disease during the second wave. So it's kind of difficult to choose.
Can I have a comment? Yeah. Can I have a comment? You know, I am Georgie Abraham from Chennai. My colleagues,
Sir.
Dr. Tyagarajan and Karthikeyan, had a patient, young man, transferred from Pondicherry with rat poisoning and in severe hepatic coma. And incidentally, he was detected to be COVID-19 positive. There was no time at all. So with all the precautions taken, they put the brother's liver into him, and he has done very well, and he was discharged from the hospital with COVID negativity. So I think probably this is the only incident where a COVID positive patient in an emergency situation with hepatic coma due to rat poison was transplanted, a live liver transplant, and successfully done.
Yes, madam.
What vaccine was given? Was it Covishield or Covaxin? Because in Covishield, portal vein thrombosis as also cerebral venous thrombosis is well reported, and as well as we have also seen cases in our country. So what vaccine was it?
It was Covishield.
Covishield. Because what was the PF4 status? Whether was fatal factor 4 antibodies positive?
We have not checked it. She came with pain abdomen, and then once she was admitted, so we did the workup, and that is, she was initially being considered. We had not even started the evaluation. She was getting the vaccination, and after the vaccination, the plan was to start evaluation. And
how old was she?
She's 39.
Because we have found in whatever cases, by and large, young females who have had their COVID vaccine, Covishield, largely after the first dose, maybe around 2 to 3 weeks down the line, but can't exclude after the second dose as well. And not many centers investigate them well. Their hematologists are not available, even if they're available, they're not involved. And they're not thoroughly worked up, but this is one thing that we all have to be aware of and pick them up with a high index of suspicion. So that
can we wind up this session? May I request the chairpersons to wind up the session? We are running short of time.
Vaccination district medical officer. Whatever adverse events following immunization, whether it is due to COVID or not, the causal analysis requires to be done, because only then we'll have data from our own patients.
We are running.
Thank you, madam. Because of shortage of time, we will have to close the session. Thank you, Dr. Rela, for excellent presentation.